Good morning. Thank you for joining us. I'm Aisha Blair, Retina Clinical Coordinator. I'm here today with Dr. David Ellenberg, a retina specialist from Ophthalmic Specialists of Michigan. For those of you that do not know, we have locations in Livonia, Dearborn, Southfield, and Madison Heights. For questions or to schedule an appointment, please call 1-800-237-3937. That's 1-800-237-EYES, or you can click the link in the comments below. Now, Dr. Ellenberg, before we get started, I know there's a few things you want to say.
So a few housekeeping issues. I'm David Ellenberg. I'm a retina specialist, as Aisha said, at Ophthalmic Specialists of Michigan. A few housekeeping things. We're not wearing our masks. We're part of each other's inner circle. We're vaccinated. We just didn't want the microphone to be muffled, and so everybody couldn't hear it, so we just took our masks off just for this interview. So I just wanted to preface that. Second of all, I wanted to thank everybody for joining us and encourage questions. We really want to try to make this as informal a discussion about diabetic retinopathy or diabetic eye changes, diabetic eye disease as possible. And the point of this is for those who logged on, we really appreciate anybody watching this later. We appreciate that as well. But the point of this is to get anybody who has questions and get everybody's questions answered and just get some common information out there about diabetic eye disease. As it is very common, and we know diabetes is very common.
And like Dr. Ellenberg said, we are here today to discuss diabetic retinopathy. So let's get started. Dr. Ellenberg, what exactly is a retina?
Perfect. So, and again, please interrupt with questions at any point. So the retina is the back of the eye, the nervous tissue in the back of the eye that's responsible for taking sight and images and transmitting it through the optic nerve to the brain so that we can see. So we brought the eye model here today, and basically what this is if you can imagine this is an eyeball, or a model of an eyeball, and we sliced it in half, and we're looking at the inside of the eye. So here's the front of the eye, here's the back of the eye. The very front part of the eye right here, this clear part of the eye, that's called the cornea, and that's the front surface of the eye that everybody can see. Next, you have the iris and the pupil. Now, the iris is the colored part of the eye. So when we talk about someone having green eyes or blue eyes or brown eyes, the iris is responsible for that color. Right behind the iris is the lens. The lens is what you always hear about people who have cataract and cataract surgery. That occurs in the lens. So when someone has cataracts or cataract surgery, the cataract surgeon goes in, removes the lens, and puts in a brand new lens, and that's what clears up the vision. Now, what we're here to talk about today is all the way in the back of the eye, and that's the retina. So cornea, pupil, lens, light comes through all that and projects onto the retina. That's all the way in the back of the eye. You can see the blood vessels here. The retina then takes the signal, sends it through the optic nerve to the occipital cortex, or the part of the brain that's responsible for vision, and that's how we see. So you can imagine that the retina is extremely important for vision, and it's extremely delicate and sensitive because it is nervous tissue, just like the brain, and the best way to handle any nervous tissue is to prevent damage and treat damage early when possible, because often once the nerves are damaged, they really don't quite recover as well as we'd like. So that's the retina all the way in the back of the eye. That's where the diabetes affects the eye, and that's the term where diabetic retinopathy comes from. And that's going to be the point of the discussion today. So that's the area we're focusing on. Any questions? Again, I just want to remind everybody this is supposed to be very informal. Ask any questions if you need.
Okay. So what exactly is diabetic retinopathy and what causes it?
Okay. So diabetic retinopathy, like I mentioned, is damage to the blood vessels in the back of the eye or in the retina. And when the blood vessels are damaged by high blood sugar, so the high blood sugars does damage to the blood vessels then leak and bleed, and they cause bleeding into the retina and into the eye, and they also cause swelling in the retina, and that obviously damages the nervous tissue in the retina, and it causes vision damage and sometimes permanent vision loss. So that's where the term diabetic retinopathy comes from. Diabetic because it's diabetes that's causing it, and retinopathy because it's damage to the retina. So if you look here, here's an image of a normal retina. So if we were looking at the eye model, this would be an image focusing just on the back of the eye. So if we took an image and we focused it right on the back of the eye, it would look something like this. Here's the optic nerve. Okay, this is a normal, healthy eye. This area in between the large blood vessels is called the macula. That's where the term macular degeneration comes from that many of you have probably heard. The fovea is just the middle part of the macula. The main issue that diabetes affects is the blood vessels. And what happens is the high blood sugar causes damage to the blood vessels. The blood vessels then start to leak. And once they leak, you can imagine you get bleeding into the retina and into the eye. They also leak into the retina and cause swelling of the retina. And that's something called diabetic macular edema, but that's because the blood vessels are leaking and causing swelling in the retina. Sometimes, in more advanced stages of diabetic retinopathy, the blood vessels are so damaged that the retina tries to make its own blood vessels to try to compensate. That's called neovascularization. Unfortunately, those blood vessels are very unhealthy and very weak, and they bleed into the eye, and we can end up with an eye filled with blood, or they can even cause a detached retina. So that's what happens when we get to more advanced phases. So I'm going to try to take this normal image down. So this is just a schematic of what I talked about. So you can see that you're getting damage to the blood vessels. The blood vessels are leaking. You're getting bleeding in the eye. You're getting something called cotton wool spots, which has to do with the fact that the blood vessels are so damaged that the retina is not getting any nutrients or oxygen, and you get what's called an ischemic area of the retina. And then you can get these unhealthy blood vessels that grow, this neovascularization, that causes bleeding into the middle of the eye and can cause detached retinas. So this is just an example, a comparative example between how we want the retina to look and how it should look, and how it looks when there's a lot of diabetic damage or diabetic retinopathy. And you can see how important it is to try to prevent this and to try to treat it early, because this doesn't always recover completely once it's there.
Do we have any questions? Okay. So, Dr. Ellenberg, a patient comes in, they have some of these changes. How would you treat this?
So, like I mentioned before, the best way to treat this is to prevent this with good blood sugar control, and that's really the number one best way to treat this. If someone has diabetic retinopathy and it's starting to cause bleeding and swelling like we talked about, then there are different treatment modalities we can use to treat it. And the studies and research have shown that with diabetes, really treating it pretty early and pretty aggressively is the best. The three mainstays of treatment are medicine inside the eye, so we can put medicine inside the eye with injections. We can do laser treatment or laser surgery, or in some cases we need to do retina surgery where we actually have to do a minor surgery where we can go and fix some of the damage that the diabetic retinopathy or diabetes has done to the retina. So those are the three mainstays of treatment. You have medicine, laser, and then sometimes surgery. But again, preventing it is the best way, really. Preventing the damage is really the best way to combat this.
Which leads us to, how do you prevent it?
So the best way to prevent diabetic retinopathy is blood sugar control. So, like I was mentioning, diabetes itself does not cause damage to the retina. What's causing? We have a question? Okay, perfect.
How does high sugar actually damage the blood vessels?
So the lining of the blood vessels is very sensitive to the high sugar. That's a great question. There's something called periocytes, without getting into all the scientific detail, but basically the sugar causes damage to the lining of the blood vessel, and you can imagine as blood is flowing through the blood vessels have to be very tight to keep like a pipe, right? You don't want a leaky pipe. It has to be very tight, and these cells are really stuck together real tight. What the sugar does is the sugar causes damage to the cells that line the blood vessels, and it makes those junctions leaky. So that's really what's going on. The sugar is causing damage to the lining of the blood vessels. It's making them leaky, And that's where you start getting the bleeding and the swelling because the blood and the lipid leak out of those leaky blood vessels and cause the diabetic retinopathy. That's a great question.
Another question, at what level A1C does damage occur? If I keep my A1C below 7, is there any chance of damage or is there a risk?
That's another great question. You asked a question we were going to ask anyhow, so we'll get to it now. The answer is good blood sugar control and good A1C control absolutely helps prevent diabetic retinopathy. I never like to say, oh, if someone keeps their blood sugar under 7, under 6.5, they're never going to get diabetic retinopathy. But the chances of them getting diabetic retinopathy and the chances of getting significant advanced damage is much, much lower and can be preventable with good blood sugar control. So you do want to, there's some talk now that keeping the A1C under 6 isn't necessarily necessary. I recommend everybody talk to their endocrinologist and primary care doctor about that. But definitely you want it under 7, under 6.5 range to prevent the diabetic retinopathy. And the short answer is yes, you can prevent it. Like I said, I don't want to say you're never going to get diabetic retinopathy if your A1C is under 7, but the chances of you getting visually significant damage is much, much, much lower if the A1C is under 7, under 6.5. Absolutely. Great question.
Do you have any suggestions for supplements or vitamins to support eye health?
So there is an eye supplement, but it's really not for our discussion today because it's mostly for macular degeneration, and it's called AREDS 2 supplements, but it's really not for diabetic retinopathy. The mainstay of preventing diabetic retinopathy is blood sugar control. Eating well, low carb diet, everything that the primary care doctors and the endocrinologists always talk about, the same thing that's going to prevent damage to the kidney and damage to the heart and damage to the nerve, that's the same thing that's going to prevent diabetic retinopathy and damage to the retina. It really all boils down to blood sugar control. So I wouldn't necessarily recommend a supplement for diabetic retinopathy as much as I would recommend controlling the A1C and controlling the blood sugar. That would be the mainstay of trying to prevent diabetic retinopathy.
How long does a patient have to get shots in the eyes?
Oh, okay. Do I need to repeat some of the previous questions? No. So I think everybody can understand some of the previous questions. Sylvia's behind the camera. I didn't realize we may not be able to hear her
So
question.
the question is, how long will the patient have to get injections in the eye?
So we're definitely jumping ahead a little bit, but let's go anyway. So to preface that question that was asked, excellent question, is that if someone has diabetic retinopathy to the point where it's causing swelling or causing bleeding, one of the ways we treat it is with a medicine that we do with injections in the back of the eye. And the most popular question is how long I have to do this for. And the worst answer, which I give all the time, is I don't know. But the answer really is you start it very aggressively. So you start it every month, every 6 weeks. And the diabetic retinopathy really guides the treatment. If the diabetic retinopathy is responding real well, and if after many, many treatments, the diabetic retinopathy has improved and the bleeding has improved and the swelling has improved, then we slowly start to wean off the treatment. That's called treat and extend, where you start to say, well, let's say what happens if we treat it every 2 months, or what happens if we treat it every 10 weeks, or what happens if we treat it every 12 weeks, and we slowly do that until we eventually can get someone off the injections altogether. But one of the take-home messages that I always talk about with individuals and people who need the injections, once it's gotten to that point, it's really a marathon, not a sprint. So it's going to be a long haul, unfortunately. The good news is the treatments are amazing, and they're way better than we had 15, 20 years ago before we had these medicines. But it is a process getting there, and it's a treatment, it's not a cure. So you do have to be on it pretty continuously, at least in the beginning, to have it work properly. I hope that answers the question for the most part. There's no way to concrete say how long it's going to be. Everybody's eye is different. But anybody who needs the injection should approach it with the attitude that it's probably going to be a while.
Next question. Carmen asks, can you see damage happening without the blood vessels
No.
So the question from Carmen
Oh,
was, can you see the changes without the blood vessel? Was it without the blood vessel? So can you see changes before the blood
Right. So
leakage in
some
the
of
blood
the
vessel?
so the changes normally that you see early is damage to the blood vessels. That's a great question. But yes, you can get early damage that where before the blood vessels are really leaking, or when they're only leaking a very little bit. Those are called microaneurysms, and that's actually the earliest sign of diabetes in the eye. And that's what when we see someone who has that, normally what I'll tell them is you have early changes. It's not bad. It doesn't need treatment, but we got to get those sugars down so that it doesn't advance, and at times we can even reverse it. An example of a little microaneurysm on the picture is probably right here. So you can see it's just a little outpouching of the blood vessel, and that would be an early change before the blood vessel's actually leaking real bad and causing all this bleeding in the eye. You would see those microaneurysms, and that's a sign that the wall of the blood vessel is starting to get damaged and starting to get thin, and that's why you're seeing that outpouching or that microaneurysm. Great question.
Richard asked, vegetables like carrots that have beta carotene help ward off the diabetic retinopathy?
So
Can food like beta carotene with it that have like carrots help with diabetic
as a
retinopathy?
general rule, we say green leafy vegetables are good for the eye. Once again, that's more for macular degeneration and those types of changes than diabetic retinopathy. That being said, of course we encourage healthy eating, a well-balanced diet full of green leafy vegetables, fruits, vegetables. But the mainstay of preventing diabetic retinopathy is sugar control. The supplements are good, the green leafy vegetables are good, but it all only helps, and it all boils down to keeping those sugars under control. That's really ultimately what's going to keep the diabetic retinopathy away. Yes, some of these things are good for other retina issues, but the diabetic retinopathy is caused by the high blood sugar, and that's really what it boils down to. Any more questions, Sylvia?
Once one develops diabetic retinopathy, is there a way to reverse the damage completely with injections, or the injections just
So the question is once someone is diagnosed with diabetic retinopathy, do the injections totally reverse it, or do they just treat it, basically? That was, yes.
So another great question. So there's actually some of the more recent research that has come out in the last 5, 6, 7 years as we're learning more about these injections is that once someone needs injections, if they're treated properly and aggressively, like I was saying, early, and we do it aggressively early on and then try to do that treat and extend, you can actually decrease the level of diabetic retinopathy by 2 stages. So in the retina field, we'll grade or stage the diabetes between mild, moderate, severe, very severe, proliferative. There are different grades. If you're treated well, you can actually bounce back to the level of 2. I don't know if I would say you're going to completely eliminate all the changes in the retina, but you can definitely get it to the point where it's not visually significant and not doing any severe damage. And that's actually some of the new studies have shown with regular injections, we can drop it down by 2 levels, which we never really thought. It's actually fascinating. Someone could come in with severe non-proliferative diabetic retinopathy. That's one of the stages. And if they're treated properly, within a year, 2 years, they could drop all the way back down to mild diabetic retinopathy. So the answer is yes, you can reverse it and improve it. The most important thing is obviously you want to stop it from getting worse, but if it's treated properly and follow-ups are done right and compliance and the A1C comes down and the sugars come down, then yeah, you can reverse it, absolutely.
Maria asked, how often should you have an eye exam?
The question was, how often should you have
It's
an eye
great.
exam?
We don't even have to ask any of our questions. Everybody's asking our questions. So anybody with diabetes should have an eye exam at least once a year. And that's assuming that they have diabetes but do not have diabetic retinopathy. So I'm sure anybody who's seen the endocrinologist or seen the primary care doctor, they've been told if you have diabetes, you have to get your kidneys checked, you have to get your eyes checked. The eye exam should be a yearly diabetic eye exam for anybody with diabetes. Now, if there are diabetic changes that the doctor sees in the eye, even if it's not at the point where it needs treatment yet, they may decrease that interval. So they may say, you know, we're seeing some changes. You don't need treatment yet, but I think it at least warrants following it every 6 months or every 9 months, depending on the level. So that'll be dictated by how much changes and how much diabetic damage there is in the eye. But anybody with diabetes, the short answer is needs to get checked at least once a year. And that is for a dilated eye exam. So the eye needs to be dilated, and the eye doctor needs to look in the back of the eye so they can see the retina and see if there are any changes back there.
Oh, someone has a question about eye pressure.
For sure. I'm going to be real brief about eye pressure because eye pressure is really a glaucoma issue. And hopefully, if this is well received, we'll do more and more of these on other topics. But an eye pressure has to do with glaucoma. Like anything with a closed system, a basketball, a football, the eye has a pressure, and there's a certain pressure that we want in that eye. The general rule of thumb is under 20, but the glaucoma doctors will be upset at me for saying that because some people actually need it even lower than under 20. So that's my brief discussion about eye pressure, and that's why when you go to the eye doctor, they always check the eye pressure, because if it's really high, that's a sign that someone may be developing glaucoma, but we'll reserve that for the glaucoma Facebook Live to discuss more, and maybe one of the glaucoma specialists could talk more to that.
Yes, so what exactly would a patient notice?
Okay. So one of the big things I want to emphasize when everybody talks about warning signs is there are warning signs for diabetic retinopathy, but once someone is seeing warning signs, the diabetic retinopathy is fairly advanced, and the retina has already had some damage to it. So I'm going to discuss warning signs, but we really don't want to wait till warning signs to diagnose diabetic retinopathy. As I mentioned, the real way to diagnose diabetic retinopathy and to evaluate it is to have yearly eye exams. The warning signs we can get if the diabetic retinopathy has advanced is a lot of floaters. If there's blood in the eye, you'll see the blood floating around, and that'll be seen as a lot of floaters. You can see blurry vision if there's swelling in the macula. You know, that's this area. So if there's swelling in the macula, you can get blurry vision or distorted vision. Or you can get a sudden onset of hazy vision if one of the new blood vessels all of a sudden bleeds into the middle of the eye and it's floating around. Someone could get all of a sudden very hazy vision. But I can't emphasize enough that once we're seeing warning signs, the diabetic retinopathy is fairly advanced and there's already been some damage to the retina. So I don't want to give the false impression that people should wait for warning signs to get their diabetic retinopathy diagnosed. We really want to be diagnosing diabetic retinopathy and being on top of it before the warning signs show up.
Another question?
Are eye exams every 6 months considered a diabetic eye exam? And if not, do you go to an ophthalmologist or is an optometrist exam sufficient?
Okay, so the question was, is every 6 months considered an eye exam? And should you see an optometrist or an ophthalmologist?
So you need to get a good dilated eye exam. Whoever can give a good, adequate dilated eye exam, if they're prepared for that and they're set up for that, that's what someone needs. A good dilated eye exam where they're examining the back of the eye. Now, is every 6 months considered a diabetic eye exam? Of course it can be, but for someone who doesn't have diabetic retinopathy and has no eye issues and no eye problems, a yearly eye exam is probably sufficient. Now, I can't say if there are other issues like the pressure is a little bit high or there's some macular degeneration changes or, there are some mild diabetic retinopathy changes, then yes, your doctor might tell you to show up every 6 months or more often. But the standard thing is that someone with diabetes that does not have any diabetic retinopathy or any eye issues should be seen once a year for a full dilated eye exam by an eye care professional that's comfortable and set up to do a dilated eye exam.
Okay. I've heard you tell patients that the up and down blood sugars are not good. Like, can you just discuss that a little bit?
Absolutely. And so this is something that the primary care docs are talking a lot about now, the endocrinologists are talking a lot about now, and we're learning more and more about it, is someone can come in with an A1C that doesn't look too bad because they're running high and low. So the average ends up being okay. But exactly what Aisha says, that's not the same as someone who's consistently running, in the 100s, 110s, 120s, 130s. If you're running 250 one day and 50 the next day and 250 and 150, and 250 then 150 then 50, you may end up with an A1C that doesn't look so bad, but that is not a good blood sugar control. And I think anybody who's had diabetes unfortunately knows that. The biggest challenge is keeping it in a fairly tight window, but that's also what prevents the most damage. And we're also learning that blood sugars too low are really not good either. So you really want to avoid the real highs and the real lows. You really want it like a steady Eddie. As hard as that is, that's really where you want it, in a fairly tight window. You don't want to see 250, 50, 250, and then get this false sense of security because the A1C isn't that bad.
You answered one person's question already with that. Is there a specific age at which yearly diabetic eye exams are needed, or is it a good idea to start right when they're diagnosed?
Right when they're diagnosed.
So the question was,
I keep forgetting to ask the questions. They can hear Sylvia. Go ahead.
The question was there an age that the diabetic screening should start, or should they start as soon as they're diagnosed with diabetes?
Perfect. So one of the things with diabetic retinopathy is it can affect any age group. And the worse the blood sugar, the longer you've had diabetes, someone's had diabetes, the more likely they have diabetic retinopathy. And that's why it's such a devastating process. In fact, it's considered the most common cause of blindness in the U.S. in the working population, which is the under 65, 75-year-old population. So the answer to the question is immediately. When someone's diagnosed with diabetes, they need to get their eye exams right away, especially if it's type 2. Because what we know is when someone's diagnosed with type 2 diabetes, they've likely had diabetes for much longer than that. Sometimes you can say if someone has a type 1, you can wait a year or two to get their diabetic eye exam. But really my recommendation is as soon as someone's diagnosed with diabetes, they should get their eye exam. If there are no changes and the eye looks very healthy, then they need to get yearly eye exams after that. So there's not an age group criteria. There's not a cutoff. Anybody with diabetes needs at least yearly diabetic eye exams.
We'll take this last question, and I think we can close out with a closing message. Are Dr. Ellenberg considered sufficient for a yearly eye exam?
Am I?
So the question was Dr. Ellenberg's exams considered a yearly eye exam?
Yes. My exam would be considered a yearly diabetic eye exam, absolutely. For glasses or for contacts or for glaucoma or for things like that, I always recommend people see those specialists. So, there are docs out there who specialize in glasses and contacts and glaucoma and cataracts. So if someone has those issues, that's a better resource. But for yearly diabetic eye exams, absolutely. In fact, the majority of my patients that I see in the office have diabetes or diabetic retinopathy. In fact, between diabetic retinopathy and macular degeneration, those are two of my main specialties, and those are that population makes up most of my patient base, diabetic and macular degeneration. Then there are detached retinas and scar tissue on the retina and other things that people come to see me for. But I'm a retina specialist, so anything affecting the retina, which is diabetes, macular degeneration, detached retinas, floaters, scar tissue on the retina, blurry vision that's being caused by an issue in the retina and not a cataract or other eye issues. That's why patients generally come to see me. So I guess the short answer is yes. If it's a diabetic eye exam, then yes, my exam would suffice.
So what would be your take-home message?
So I know I've emphasized this a lot. first I want to thank everybody for joining us, and I really want to thank everybody for their questions, because this is our first one, and we were worried we weren't going to get questions, and we really appreciate all the questions. The questions were great, and it did exactly what we wanted to do. We had an informal discussion about diabetes. My take-home message is exactly what I've been hammering home the whole time. Blood sugar control and eye exams. Anybody with diabetes needs to be cognizant of controlling their blood sugar. That's ultimately what's going to prevent all that damage, and getting their eye checked, at least on a yearly basis, and more so if needed. I'm happy to do diabetic eye exams. Like I said, that's my specialty, but anybody who's comfortable doing it, that's fine. Anybody who wants to see me for their diabetic eye care, we're happy to see them. But those are the take-home messages. Blood sugar control without massive fluctuations, and getting the eyes checked yearly. And I can't emphasize that yearly eye exam enough, because what we'll sometimes see is someone will come in, get their eyes checked, their eyes will be fine, and then they'll kind of get this false sense of security because they're not seeing any changes. They'll come in 5 years later, and the eye will have irreversible damage to it. So you really want to avoid that, and the best way to avoid that is aggressive early treatment when necessary, and getting the eyes checked so that we can diagnose the diabetic retinopathy early before you end up with all that. On a final note, I want to thank everybody for coming. I want to thank everybody for their questions. Please call us if you have any questions. And anybody who's watching this later on, thank you for watching it anyway.
And just a second, Dr. Ellenberg, thank you again for joining us today. You can schedule an appointment, osmich.com. Give us a call anywhere. Just keep getting your eyes examined, and have a beautiful day. Thank you.